Welcome to another interesting case. This is a seemingly routine case. She's a 70-year-old lady who's come for a cataract surgery. The other eye is pseudophakic. I've operated about 8 years back and it was uneventful and she's doing fine. Since the cataract is slightly hard, an optimal sized rhexis is achieved. This size rhexis should be good enough to manage this dense nucleus. So as is typical for me when I decide to do a direct chop, I'm just going to make a small central pit using continuous torsional, and then I'm going to switch to the chop mode where I'm going to bury the tip into the substance of the nucleus. The vertical chopper goes down and there is a lateral separation. So subsequent chops are being done. Things are seeming to be going on pretty well. There doesn't seem to be any surprise. The couple of fragments are emulsified and then the iris is coming out through the leaky side port. So I'm just going to reposition it and inject a little bit of OVD, and then the remaining heminucleus is being dealt with. So this is a standard technique. So far so good, nothing unusual. And the last piece fragment is also taken care of. So I fast forward the video so that we can cover some interesting facts later. So once the final piece is out, I'm thinking just to put the lens and finish it off. And then something catches my eye. There is a definitive line which I am seeing here, a folded wrinkled membrane, and my phaco tip has just caught it. And immediately realized that this looks very suspicious. And as a thing it shouldn't be done, as a reflex, I just exit out of the eye, which is not to be done. I'm just irrigating a little bit of an intracameral anesthetic. The patient is slightly uncomfortable. Viscoelastic is injected into the eye. The soft epinucleus is burped out, and now the visibility is great and my worst fear is confirmed. I'm having a very huge PC tear. It's almost from equator to equator. This edge is paracentral and this is the other edge of the capsular tear. So this eye we had planned a single piece, a hydrophobic acrylic lens, and the situation is such that now I'm hesitant to consider this. The thoughts which are running in my head right now, as I can see, the anterior hyaloid is still intact. Now this patient is planned for a single piece lens. With this current situation, I don't think I'll be comfortable placing the single piece lens into the bag with an equator to equator tear. And number 3, I need to remove the cortex without rupturing the anterior hyaloid. That's the thing which I'm planning. So as I've asked my assistant to get the equivalent power of the multi-piece lens ready, my plan is to go ahead and remove the cortex. The chamber is maintained well and deep, and there's a little bit of a leftover cortex all around, and I'm very slowly and steadily aspirating all the cortex. At this point, my main focus is ensure that perfect job is done at this stage. I'm not bothering at what stage it happened. So I've got all the time in the world to ponder about it later once the surgery is finished. At this point, my focus is just to do the best I can in this situation. One quadrant of the cortex is taken care of, and then the cortex in the other quadrant is also taken care of. Even at this stage, I'm pretty certain that there is no rupture of the anterior hyaloid phase. A practical tip here is, before injecting the multi-piece lens, I'm going to create some space here using cohesive OVD. So using this specific cohesive OVD, which is just sodium hyaluronate, helps us to maintain the space when you're trying to push in this lens through the small phaco incision. By creating this space and maintaining it, there are lesser chances of the haptic going under the anterior capsule, and that's the reason I prefer to have this OVD placed at this particular stage. The proximal haptic goes under the iris and above the capsule, and the second haptic is gently dialed over into the sulcus. Now, before achieving optic capture, I would want to remove some of the OVD which is sticking onto the back of the lens. At this time, I realized that the posterior capsular flap is adjusted the visual axis. At this point, I'm wondering whether this posterior capsular split, which is right at the visual axis, could it cause any visual disturbance to the patient? So hence I decide to trim it using a cutter itself. I go back and use my 23G cutter to trim it, and also probably do a limited anterior vitrectomy, although at this stage there is no indication since the anterior hyaloid was still intact. The cutter comes out, and before closing I just want to confirm the absence of vitreous in the anterior chamber by using triamcinolone acetate. The optic capture is very subtle in this eye, simply because capsular axis is slightly bigger than what I would have preferred for an optic capture. Nevertheless, there is definitely some amount of support, and this is going to hold the lens quite well. So the side ports are hydrated so that we don't allow the chamber to shallow. If the chamber shallows, again the optic can pop out of the orexis margin. Pilocarpine ensures that the pupil is round and I have not missed any vitreous fiber. The wounds are hydrated, that's it, the case is done. So these are the post-op pictures. The patient did well, and at the end of 6 weeks, we routinely evaluate the retina. The retina was fine and the OCT macula was also alright. So when did the PC tear actually happen in this patient? Let us rewind and see. Now is the time to discuss what happened in this case and when it happened. So obviously we had a PC tear. I'm just interested to know what was the first time where possibly I could have identified it. This is the scalp. This is absolutely fine. The tip is buried. The first chop is done, and we can see a very bright red reflex beneath it. But in these mature white cataracts, sometimes, without an underlying nucleus, things also looks a little bit bright. So probably the capsule is already split at this stage. So we move on to the next step, and during this chop, when you can see that the fragment is just moved up, definitely the red glow is very much enhanced, and at this stage, I think the PC tear is already staring at me. So it is great fortune that the anterior hyaloid was not ruptured and everything was intact. And even with an open posterior capsule, I could emulsify the nucleus without much of an issue. Finally, I detected at this stage, but definitely there was evidence of a posterior capsular tear beforehand only. Now, why did I miss it? Why did I not diagnose it? So the only clue here was, a bright red reflex, which was slightly unusual. But, it was not something out of the ordinary. It is when you have a mature cataract and there's absence of cortex in the epinucleus, there is always going to be red glow, and I did not find any demarcation line between intact and the PC. So just a red glow, so that's the reason I could have missed it. But the most important reason for missing the diagnosis was the chamber equilibrium was never compromised. The chamber was stable until the last moment when I caught the PC. So the reason why the chamber is stable and there's no fluttering or sudden deepening of the chamber is the anterior hyaloid is intact throughout. So the one lesson which I want to share with all of you is that how do you diagnose the presence of a posterior capsular tear but an intact anterior hyaloid? So in this case, we can see there's a PC tear which has happened way early in the beginning, or probably it was there initially itself. But at no moment could I see that there's a sudden deepening of the chamber or change in the dynamics of the antechamber equilibrium. This is an extremely important sign. So once you have a stable chamber, there is no fluttering of the chamber even for a fraction of a second. That's an indication that the anterior hyaloid could be still intact. And that's the only reason why the fragments did not drop. There's a very famous quote. I'm not sure who told it, and the quote is, "It's better to be lucky than good." Thank you for watching and hope you found this helpful.